Good afternoon, everyone, and thank you for joining today's Aspire to Knock Out Pneumonia Readmissions webinar series, webinar number 3, Design a Portfolio of Strategies and Operational Dashboard. We would like for these meetings to be very interactive, so we're anticipating that you will be highly engaged in today's session. We encourage you to ask questions and share information throughout the webinar today utilizing the chat panel. We will keep all lines muted to cut down on feedback, distractions, and echoing. Before we get started today, I'd like to go over the logistics for today's session. As I stated before, all lines are currently muted and in listen-only mode. Please chat with your colleagues, hosts, and panelists throughout the webinar today utilizing the chat panel. And you can find it by clicking on the chat bubble in the bottom center left of your control panel. Please make sure your to setting is set to all panelists and attendees. This session is being recorded and will be made available on the NC Quality Center website and through email notification shortly after the conclusion of today's session. Facilitating today's webinar for you is Karen Southard, VP of Quality and Clinical Performance Improvement of the NC Healthcare Association, and presenting today for you is Dr. Amy Boutwell, founder of Collaborative Healthcare Strategies. And at this time, I'd like to turn the presentation over to Karen.
Okay, hello everyone and welcome. So glad everyone could join us. So today we're using a little different platform. It's Zoom, and it's really designed for some interactive discussions during the course of it. So be prepared, watching your chat. I'll be prompting you to give us some discussion as well as Dr. Boutwell. We're just so thrilled to have Dr. Boutwell. We've been having calls with many of you throughout this month, Trish and I, and we just heard so many wonderful things about how you're really being able to grasp the information, use the data, and that some have even adopted as a readmission strategy using Aspire and following it through with their team. So that's exactly what we are delighted that it's very good information, timely, and it's really helping you guys make some good change. So with that, I am excited to get started and hear Dr. Boutwell talk about our Aspire Knockout Pneumonia Readmissions and webinar 3. Dr. Boutwell?
Okay, great. Thanks, Karen, and hi, everyone. Thanks for joining. Sarah, I think if you could pass me the ball, that would be great, or advance to the next slide. So today is webinar 3, and as all of you know, the purpose of our webinar series is to really help advance and accelerate your work, and it's such a great collaboration with your NCHA team that you're having coaching calls in between these webinars and really putting this information to use. So, so we want you, as we go forward, I really appreciate the NCHA team getting us onto the Zoom platform because as I have been in the past 2 webinars, today again I'm going to pose discussion questions and questions for your consideration, and welcome your interaction in the chat as we advance our work together on reducing pneumonia readmissions. What we really want to do in this webinar and in the rest of our webinar series is to learn from the bright ideas or from the challenges that you're encountering as you do this work every day. And so this is just a reminder of the Aspire guide and the spread of these methods not only across North Carolina, but also across the country. The Aspire framework, for those of you who are just joining, we're unable to hear the presenter. Sarah, can you hear me? And Brian is saying he cannot hear me. So I'll, just as long as you can hear me, I'll keep going.
Yes, we can hear you, Amy, and we're working with Brian to fix his audio now.
Perfect. Okay, great. So as a reminder, I know not all of you have been on all of the webinars, and so indulge me in a moment in orienting the newcomers to the Aspire framework. The Aspire framework is an acronym for the evidence-based strategic approach to reducing readmissions, whatever your readmission reduction goal is. So of course, what brings us together in the Knockout Pneumonia campaign is to knock out pneumonia readmissions, and that's our collective objective in our work together, recognizing that many of your teams are working on reducing readmissions of a variety of sorts. But the two key strategies that will help strengthen and accelerate your work to get the improvements that you seek to achieve are these two middle boxes. We need to design an effective strategy based on data, root causes, understanding what resources you have, not only within your hospital, but across the continuum. And we've covered those topics so far. Today, we're going to talk about bringing that information into a strategic approach to make sure that you have a readmission reduction strategy that you have confidence in, that if you actually implement what you have, the interventions and the ideas that you have put on the table, then you will be well situated to move into implementation and continuous quality improvement to deliver those services and expect to see good results. So that's the design box. Well, then, after this webinar, we'll move into deliver, and we'll cover what I'll describe to you today as a multifaceted portfolio of strategies. And the portfolio of strategies is the deliver box. And that might include improving what we do while the patient is with us and immediately upon their transition out of the hospital. It includes reaching out to collaborate with cross-continuum providers in the post-acute care and community-based setting, as well as delivering enhanced transitional care services for patients who are at highest risk of readmission. So that's the ASPIRE acronym, and it's the framing kind of strategic approach of the ASPIRE guide. So we are working our way systematically through that content. Forgive me, I've got a little slide delay here. Okay. So this is our curriculum as you're following along. We really hope, we really hope that you'll join us for the entire series as we work through the ASPIRE guide. And sorry, I'm having a little delay, so I need to resist the temptation to hit the button twice. The objectives of today's session are really to hit two key concepts. Designing a portfolio of strategies, and then developing what I call an operational dashboard. So to orient you, I hope you all have seen the ASPIRE guide on the Agency for Healthcare Research and Quality's website. The link is here on the slide that you see, and there's of course the guide, but for today's discussion there are three tools that you might find helpful. I really believe that a tool is, really just better than a blank piece of paper, and part of the feedback that we got when we did our field work, testing and rolling out the ASPIRE guide, is that teams really wanted the editable formats of the various tools. So really, I think nice features of these three tools that I'm going to walk you through today can absolutely buy anything in these tools. So just wanted to make sure that that you are oriented to where you can find that on the Agency for Healthcare Research and Quality's website. Okay, great. So what I'd like you to do now is join me on the chat and make sure you're chatting to all see. And I'd like you to think about three questions. So hopefully by now, you are converging and pretty solid on being able to answer question number one, which is, what is your pneumonia readmission reduction aim? Question number two, what interventions are you delivering? What are you doing in order to achieve that aim? And question number three, which takes us into a new zone of discussion, do you know how reliably you're implementing those interventions to help achieve your pneumonia readmission reduction aim? So we're going to take each of these questions slowly and ask you to pause for a moment. You might be by yourself at your desk. You might be with a small team in a conference room. These questions you might be able to answer right now. And by all means, if you can't answer them right now, there are three, what I'll call, quote, simple questions. I know nothing's ever simple. Three straightforward questions that, that you should really work to have the answers to as a result of having attended this webinar. So number one is what's your readmission reduction aim? I should see fingers flying in the chat box. So I'm sure you have a readmission reduction aim, and I'm hoping that you have a pneumonia-specific readmission reduction aim statement. So just to prompt some thinking, this is a very straightforward statement of purpose, right? And we've been through this in prior webinars. We've been through this content in prior webinars. A readmission reduction aim statement is structured as, what are you going to do for which patients, by how much, by when. So these are some example readmission reduction aim statements that are from teams that I work with. You might want to reduce pneumonia readmissions for your Medicare patients by 10% by the end of the year, or reduce pneumonia readmissions for all patients discharged to home by 15%, or reduce pneumonia readmissions for patients discharged to SNF by 20% in the next year to come, or reduce readmissions for high-risk pneumonia patients by 10% by the end of us are working broadly on the Medicare penalty conditions in general. So you might say, well, our aim statement really is to reduce AMI, heart failure, COPD, and pneumonia readmissions for Medicare patients by 20% in the next year. Or perhaps you have a strategic organizational objective to reduce all-cause readmissions, in which case pneumonia, of course, is an important subgroup of that, and maybe your aim statement is to reduce all-cause readmissions by 10%, from 10% currently to 9% by next year. So there are only really so many ways to structure a well-formulated readmission reduction aim statement. It's what, for whom, by how much, by when. And so we've got reduced pneumonia readmissions and pneumonia mortality by 5%. Great, thank you. And many people are chatting in by the end of the year, so that's great. And so thank you for chatting in your aim. What I want to point out is why do I emphasize this? I emphasize this because you have to know who you're focused on, and you have to know how far you have to go. So a 5% reduction, a 10% reduction, that's a really good magnitude for, within a year, especially if we're in May and we're looking to improve by 5% by the end of the year. The magnitude of improvement tells you how intensively you need to work and how intensively you're going to need to deliver services as well. So thank you, Amy. I see a new one, reduce all-cause readmissions by 10% by June, which is next month. Okay, good. I hope you're well on your way. So what I want you to look at here is your aim statement, or inspired by some of these aim statements, and notice the teaching point on the slide. Part of your aim statement is your target population, meaning this is your denominator. The aim statement specifies who we're targeting, and success in any readmission reduction effort depends on both effectively delivering services that are going to be effective in achieving the aim, and delivering those services consistently or reliably, as we say in quality improvement. So success depends on effectively and reliably serving your target population. And really, it all starts with a clear, straightforwardly worded aim statement. So I definitely want to make sure that you all do not pass go if you don't have a clearly worded aim statement. So Brian pointed out that his goal is reduce Medicare pneumonia readmissions to 0.7 for an observed expected rate by September of 2018. So that's a really short time frame. Again, Brian, I'm sure you're well underway in your work. That's just in the next 4 or 5 months to hit that goal. So so very helpful. Good. So so question number 2 is now pivot from your aim statement to your interventions. And these are your process improvement, your quality improvement, or your system redesign interventions, right? So intervention is broadly defined. So what are you doing? In other words, what are you delivering to your pneumonia patients in your target population in order to achieve your aim? So chat in. What steps are you taking? What services are you delivering? What improvements are you making in order to achieve that readmission reduction aim? So here's some examples, and this is again the topic for today, is to really articulate what are you doing that relates to achieving examples. We're identifying pneumonia patients daily lists, saying our pneumonia person-specific the Boost 8P tool. We're identifying care plan partner and including that partner in discharge planning preparations. We're scheduling pneumonia patients for follow-up appointments within 3 to 5 days post-discharge. We're providing medications at the bedside for pneumonia patients prior to discharge. We're conducting post-discharge follow-up phone calls within 48 hours of discharge. We're conducting a warm handoff with a circle back call for all SNF transitions. We're providing transitional care with in-home telephonic contact for 30 days for our pneumonia patients. Or we're providing transitional care by following patients from SNF to home for the 30 days after they leave the SNF. So again, there are so many great ideas in terms of what you are probably doing. And thank you for chatting in terms of what steps are you taking to reduce pneumonia readmissions and hit your goal. So let me just, I hope you're all kind of thinking about your own work and also chatting in and reviewing what your colleagues are saying. We've got, we're doing post-discharge calls, scheduling follow-up appointments, doing deep dives for certain patients, using LACE to identify high risk, I'm inferring. We're looking at, we're identifying our high risk patients. Antibiotic stewardship, again, possibly a readmission reduction strategy, not always specifically related to reducing readmissions, but certainly making sure that appropriate treatment is being given. Increasing pneumonia vaccination, case management, intensive care management, follow-up appointment within 14 days, et cetera. So what I want you to really think about as I prompt these questions is there's a whole bunch you're doing, and one of the beautiful things about the Knockout Pneumonia campaign is there are things we're doing to effectively treat pneumonia patients to reduce pneumonia mortality. That's a lot of probably vaccination, antibiotic stewardship, and some other of the strategies I'm seeing in the chat box. There's what are we doing to help reduce pneumonia mortality, and the companion in the Knockout Pneumonia campaign is what are we doing to support people once they leave so that they don't need to come back if at all unnecessary. So what I want you to do, and maybe you take this part of, you don't have to have a clarity necessarily on these answers right now, but take the questions I'm asking and bring them into your next meeting and say, are we all on the same page? Do we all know what we're doing with specific regard to reducing readmissions or reducing pneumonia readmissions? And what, I'm using the word what intervention, meaning, really what are we doing to make the transitional care process or the system of leaving the hospital and being safely managed in the next setting of care for 30 days, what are we doing to build up that system? So great chat. Thank you so very much. We see, I'll just highlight a couple other things. We have a transitional care team that works specifically to reduce 30-day readmissions in the Medicare population. Anna mentioned that we've just initiated palliative care program as of yesterday. So wonderful, Anna. That's going to be a great addition to your strategy. So what I just want to point out, and I want you to again, see what your colleagues are doing in the chat, and then think to yourself, what 1, 2, 3, 4, 5, or 8 things are we doing to reduce pneumonia readmissions? And then look at the slide here. And again, I've bolded the key verb, right? And the bolded verb is your intervention. And this is the intervention that should be measured. You're probably doing a combination of things, but what we're going to want to do in an operational dashboard is ask ourselves the question, if we say we're making post-discharge calls, how many calls are being, how many completed phone calls are being made? What % of our pneumonia patients are actually getting those phone calls? And you want to be able to really drill down from the good idea that's post-discharge calls or making appointments or transitional care for 30 days. And you want to say, that's the idea. How are we actually doing by way of implementing that idea? Okay, question number 3. Do you know what % of your pneumonia patients are receiving the intervention? So this is whatever you've already chatted in, the right antibiotic, making sure patients can afford and get their antibiotics, doing follow-up calls, making follow-up appointments. Kelly, thank you so much for chatting that in. Now the question is, those are the bright ideas, those are the good ideas, those are the strategies. Question number 3, do you know what % of your pneumonia patients have received any or all of those great ideas, those great interventions that you want them to have? Where do we stand in terms of actual implementation? So examples would be, again, drawing upon what a lot of you have said already, which is we identify patients, high-risk patients or pneumonia patients during the hospitalization. Well, do you know when you're, are you identifying 100%? Rarely systems are perfect. So, so don't be, if you will, my experience in the field is don't be fooled into thinking that you have a perfect strategy or a perfect system in place. Make sure why do we miss some pneumonia patients? When you look at your data reports from CMS or from NCHA, when you do readmission reviews, are you ever surprised? Did you ever miss a pneumonia patient? Maybe they came, maybe they were on a surgical floor and, you thought for all the world they were here for some sort of surgical procedure, but for whatever reason, they aspirated, they got pneumonia, et cetera, and they ended up with a discharge diagnosis of pneumonia where you weren't expecting that, right? So this is all not to overly complicate the issue, but each one of these bullet points, you could really spend a little bit of team time saying, this is what we're doing. How do we know how consistently and reliably this part of the process is? So what % of your pneumonia patients do you identify during the hospitalization? What % of pneumonia patients received a risk assessment? What % of your pneumonia patients who were discharged to home had that appointment made before discharge? It's one thing to try to do it. It's another thing to know that you did it, et cetera. So let me just look here to see what you're saying in the chat. I appreciate all of the chat here. We had a delay in implementation of the readmission interviews, so the initial percentages were not where we would have liked. That is reality, and that's why I bring this topic to you. So thank you, Anna, for bringing that up. Honestly, I want to normalize, and I want you to expect that when you start ability with what team, your organization is implementing any one of these really good ideas, unless you are actively expect 50% or less. Just, don't excuse it, don't explain it away. What you really want to do as a champion of a readmission reduction effort is just know where you stand and move forward from there on the improvement journey. And so I'm never afraid to find out that the post-discharge follow-up phone calls only get actually answered by 30% of the patients. That's powerful. And that's powerful because then you can say to your team, gosh, you are making a whole lot of phone calls, but only 1 in every 3 are actually getting picked up. How can we improve this process? What time of day are we making the calls? Do we have good phone numbers? Are we telling our patients to expect our phone call. What can we do to go from 30% to 50%? And then you move from 50% to 75%, right? And so embrace the low numbers as actually your license to move forward and improve the process. And that is really where we have the power to get results. And so really, as champions, I encourage you to, this is why I find this topic so important, and it's actually more important at this stage of the game than good ideas on other interventions that you're not yet doing, which is why we organize it this way. I want you to know what you're doing and how consistently you're doing it right now, because really it's about process improvement that's going to get you the results you wish to see. So Deborah shared, we're currently hitting about 60–65% in getting all the improvement interventions we're working on during this project. We're just now starting project initiative. So Deborah, I might be misreading it or only seeing a part of what you're getting at, but is that in like a pilot unit, and now you're saying you're going to go spread house-wide? The answer, but these are the questions that you want to know, and it's great that Deborah knows we're at 60–65%, and now we're going house-wide, which means that you're going to have a dip before you get back up to 60–65% again. So with these as your guiding questions for the last part for the second part of this call, I'm now going to share with you how you might go about using these core concepts around articulating your strategies, designing or articulating your multifaceted portfolio of strategies, and developing an operational dashboard that will help you drive improvement based on whatever interventions you've already decided to deploy for your pneumonia patients. So this is what I call a data-informed approach. And really, as you've seen in webinar number 1 and webinar number 2, and bringing it together here in webinar number 3, you want to ask yourself, what is our aim? Our aim is to reduce readmissions, and we've got observed to expected ratios, we've got targets, we've got 6-month goals, we've got 12-month goals, right? So what's our aim? And then what does our data show? So if you're focused on Medicare pneumonia readmissions, you want to do a Medicare pneumonia data, all readmissions, payer by payer readmission analysis like we discussed in webinar number 1. And then you remember, marry the quantitative data with the qualitative data from your readmission interviews, right? So again, regardless of what target population you're focusing on, all pneumonia patients, Medicare pneumonia patients, et cetera, you want to make sure you've spoken with human beings who left your hospital after a diagnosis of pneumonia and came back within 30 days. You want to know at least 5 or 10 stories, each and every one of you, whether you're a clinician or not a clinician. You want to be able to associate a human being with the problem that you're trying to solve. It's very powerful, and that's part of data. That's qualitative data. Thus, you bring those two things together and say, well, then who should we focus on? That might be certain types of pneumonia patients, et cetera, or patients who are going to certain discharge dispositions. And then you say, what should we do? And what I've noticed time and time again in teams that say to me, Dr. Belwell, we've been working and working and working on reducing readmissions, we don't seem to be making any progress in the data. It's because they started with the interventions. They went in they said, we're going to calls, and they've been doing that for 3 years and they haven't made progress. And when they look at their data or their root causes, they realize, for example, 50% of their Medicare pneumonia discharges are going to SNF. And they've categorically not made post-discharge calls or appointments for anyone going to SNF, right? That's logical, but it's not effective. So take this to heart and really study this slide and say, did we start at number 4? And have we put together a set of interventions that are rooted in our aim, are informed by our data and root cause analysis, and targeted and such that we're doing things that are actually going to help the people who are being readmitted. So I want to introduce to you now this driver diagram concept. And this driver diagram tool, I should say, helps us create and then articulate our data-informed strategic approach to reducing readmissions. So, of course, it starts with specifying the goal and the target population. And so I've said enough about that. And then exercise number 2 is of all of the things you're doing, because we are doing numerous tasks, right? We're making appointments, we're assessing, we're making phone calls, we're linking to transitional care, et cetera, et cetera. We're doing many, many actions. Think to yourself, what are 2 or 3 or 4 unifying strategies or primary ways through which we are achieving our aim? So this is lumping what you're doing into categories to make sense of why are you doing certain things in terms of articulating your strategy. So let me show you this tool, and I'll show you the tool in action, if you will, with a bunch of examples. And I encourage you to draw out on your own notepad what you think your driver diagram would look like for your readmission work in general, or your pneumonia specific readmission reduction work. So this is a tool in the Aspire guide. It basically is a little bit of an annotated visual on how to go about constructing a driver diagram. A driver diagram is a tool that we use a lot when I was at the Institute for Healthcare Improvement, and subsequently, when Dr. Berwick went to CMS, it was used a lot at CMS as well. And any of you who have been part of any CMS demonstration projects, you actually have to put together a driver diagram as part of your proposal. So the driver diagram is a very helpful, it's basically a logic model or a strategy map to say, we understand you're going to do 100 different things, but how do all of those things link together to get us to the primary outcome of interest? And so, of course, as you can see, the primary outcome of interest is displayed on the far left of the screen, which is your aim statement. And then in the middle, you basically have usually 2, 3, 4 methods that you're going to use in order to achieve your primary aim. And then on the far right of the screen, you're going to see the specific action steps. So I just want to tell my friends over at NCHA that I don't know exactly if I'm still connected to the web or what, but you can advance the slide to the next slide. There we go. And let me just, Sarah?
Go ahead, Amy.
Can you advance the slides? In the interest of time, I think I did drop off the internet. So I'm going to pick up on slide 19, which is called Linking Interventions to Strategy, and I'll just have you walk through the slides with me, okay?
Okay, sounds good. It looks like I lost the slides, so I'm going to get them back up and get you to Linking Interventions to Strategy.
Thank you. Okay, so what you can filled in a driver diagram. And of course, recognizing that many of you, as you've already said in the chat, many of you have all-cause readmission reduction goals or multifaceted readmission reduction goals. So this might be, I wanted to share this to you. This is my mental model, really, of a generic readmission reduction driver diagram. And so, again, food for thought. You'll notice the 3 major categories that I have here in the middle: improve hospital-based care, cross-continuum collaboration, and enhanced services. That's the IRE part of the Aspire model. So those are the 3 elements of a robust, multifaceted portfolio of strategies that I always look for when I'm meeting a new readmission team. And then you can see the activities on the right-hand side which is what are you doing basically upstairs on the med-surg units? And importantly, and we'll get to this in future webinars, what are you doing in the emergency room when they come back? So I didn't want you to miss that. And then with regard to cross-continuum collaboration, what are you doing for patients going to post-acute care, getting transitioned back into the care of primary care? What are you doing for patients with behavioral health needs because they need to be linked back to their services and supports? And then how are we making it easier, more fluid, and more reliable to link to social and supportive services in the community? So that's a boatload or in the cross-continuum collaboration bucket. And then enhanced services would be the transitional care or system redesign services. And that's kind of why I just put in as an example transitional care, which you all know well, which is basically someone following the person for 30 days, whether that's a community health worker, a social worker, a nurse, a pharmacist, an interdisciplinary team of some other sort. Transitional care by definition is usually that 30-day bridge, or something in the redesign space, which might be community paramedicine, which I've learned that some communities in North Carolina are doing, et cetera. So that's kind of the archetype, a basic scaffolding of a readmission reduction driver diagram. So now on slide 20, I'm going to show you two examples of a overall readmission reduction strategy. These are from the field. Again, they're what the hospitals were doing. I think they're great. They're great examples, but I don't necessarily mean to imply that they're either perfect or the only way to do it. These are just examples of what some of your colleagues in the real world are doing as represented in a driver diagram like this. So example number one is a Baltimore hospital. Their aim, as you can see very clearly, is reduce hospital-wide readmissions by 20%. They work in a market where they have financial incentives that put them under pressure to reduce all-cause, all-payer readmissions. And so when working with them and articulating their multifaceted portfolio of strategies, we come to see, of course, they're doing a whole bunch of stuff. But hopefully you can see among the steps that they're taking, they kind of convert categories. So number one, they have a specific strategy to intervene in the ED prior to the decision to admit or the decision to readmit. And I won't walk you through all of the specific steps, but you can see that's a specific strategy. It has several actions that support the implementation of that strategy. Number two, they reliably deliver inpatient transition of care practices. So this is improving care for the patient while the patient is with us. Number three is either directly provide or link to transitional care services. So in Greater Baltimore, it happens to be that, this is common in many urban areas where there's actually a plethora of resources. And so instead of saying we're going to 100% provide patients, high-risk patients with transitional care services, they actually recognized, hey, in the middle of Baltimore, you look left, you look right, and somebody's getting care management. Kind of joking, but it was that kind of a thing. And so they said, we're either going to figure out, is the person already in some sort of program, or do we need to provide them with transitional care ourselves? And so I really liked the way, it was very thoughtful, right, and strategic way that they decided to articulate delivering transitional care services once the patient leaves the hospital. And then finally, they put a lot of specific effort into cross-continuum partnerships, and getting aligned on the same page, sharing protocols, not just meeting, but really moving from meeting into action. And so I really endorse these four strategic approaches, and you can see the detail on what specifically they do is a function of their unique organization, their unique resources, et cetera. But I think, we're all well advised to really think about using these four strategies to reduce readmissions, whether it's for pneumonia or overall. This is a very nice plan, and it's working for them. Slide 21 is another example from 1,000 miles away in Chicago. And again, not a pneumonia-specific driver diagram. This was a safety net hospital, south side of Chicago, and they actually, their major payer is Medicaid. And so they actually were not that concerned about Medicare readmission penalties because they are such a safety net hospital that really Medicaid is what was the big issue. And there were many reasons why the hospital was motivated to slow the cycle of utilization for Medicaid. And so I share this because I know not everyone in North Carolina would be in the same boat, but it's illustrative of my belief and my strategy that every readmission reduction strategy has to be done in context of your hospital and your case for change and your resources. So back to Chicago. So their case for change was reduce all readmissions by 20%. We really don't want people coming back if they don't need to come back. And so they had a 3-part strategy. And again, this is so real and honest that I share it with you because for those of you who are working at hospitals where you kind of think you're maybe just getting started, this is the example for you. This hospital was very honest. They said, you know what, we haven't really been paying attention to readmissions because, the Medicare penalties haven't affected us. We haven't really gotten on board with the whole vision, so we're just starting. So box number 1 is, I think, a very germane, relevant, necessary step. Number 1 is their first strategy, first and foremost, was they needed to create the infrastructure and capacity to drive continuous improvement. They really didn't have, they were starting at square one, if you will. And so that involved developing the capacity to review and track data, to do root cause analysis, to engage stakeholders and have team meetings and learn to trust each other, that readmission wasn't seen as someone's error, but rather an opportunity for improvement. And I'll tell you, they gave a lot of attention to this first box and those relevant action steps, and they were stronger and better off for it. So again, I really think that if that's reflective of where you feel like you're working right now, then that's honest, it's real, and it's necessary. You can't get results unless you've done this work. So great. So then their other two strategies: improve and enhance what we do while the patient is here, and then ensure we're linking to follow up and services. And so they didn't have the wherewithal to deliver transitional care, but they said, they had a strategic commitment to figuring out what is the patient already connected to, what do they already qualify for, and they put specific effort into making sure the person is reconnected to whatever services and supports they already had available to them. So again, very different driver diagram, but nonetheless effective, and then they got results as well. So moving on to slide 22, I've teed up 2 pneumonia examples, and again, you can take these back to your teams, and I'm not trying to tell you what to do. I'm just trying to paint a picture as to how you can use these concepts and apply them to your own work. So, for example, in pneumonia example number 1, here's a team that's trying to reduce Medicare pneumonia readmissions by 10%. And it's really important to specify Medicare pneumonia readmissions, because if you're working on Medicare pneumonia readmissions, you are going to need to have a strategy that deals with your pneumonia patients discharged to post-acute care, period. If you're dealing with, I'll just say the counterpoint, which might be reduce Medicaid pneumonia readmissions, well, you're going to need to have a strategy that involves linkage to home and community-based services like CommuniCare North Carolina or any other Medicaid care management entity, right? So that's why I am I keep coming back to your aim statement and your target population and your denominator. That drives what your interventions should be on your driver diagram. So this is, again, just illustrative here on pneumonia example number 1. You can just kind of visually appreciate that there's a robust portfolio of strategies that involves a handful of things that we do while the patient is here, really, really good warm linkages and circle back practices, for the transition and delivering enhanced transitional care services, both attending to the patients who have been discharged to SNF, because those are among your highest risk patients, as we showed you in webinar number 1, as well as the patients going from being discharged to home. And so, so again, I recommend you discuss this as a team. And then pneumonia example number 2 is much simpler on slide 23. This team is looking to reduce pneumonia readmissions by 20% over the next 12 months. And so really using the 3 constructs of the 3-part portfolio of strategies, what you can see is a very elegant model where we identify and refer all pneumonia patients who are being discharged to home for transitional care. And we happen to know that's 2 discharges a day, right? You want to know you're well enough to. So this hospital, smaller hospital, somewhere in North Carolina, and what we're doing is we're saying all pneumonia patients who are being discharged to home, really the main thing we do while they're here with us, besides great pneumonia care, is we make sure we link them to transitional care if they're going home. Simple, elegant. Number 2 is for any of the patients going from our hospital to skilled nursing facility, we do warm handoff and a circle back phone call for all of our pneumonia patients being transitioned from our hospital to the SNF. And that's, you know, about 2 discharges a day as well. And then with regard to the enhanced services, we do have 1 social worker and 1 community health worker who are our transitional care workers, and they're the ones that we're linking our discharges to home to, whether or not it's with or without home care, and they follow the pneumonia patients doing whatever they need over the 30-day period. So this program, as simple as it looks, would get this team results. Again, you know, if right-sized to a smaller community hospital type of an environment. So just because I say a multifaceted portfolio of strategies, I would be remiss if I implied that that means you have to be doing 20 things. You can be doing 3 things and doing them well and doing them for all of your patients on a consistent and reliable basis. So slide 24. Once you articulate your own driver diagram so that you and your team can see on paper, what are we doing to reduce pneumonia readmissions, then you can use that exact same driver diagram as a little bit of a gap analysis and as a tool to stimulate improvement in and of itself. So a driver diagram does not have to be a static document. It should be a living document. And you can ask yourself and your team these questions over time. You know, have we captured everything? And where you find, you know, there's something new that you didn't know about, put it on the driver diagram, on your strategy map. You know, you ask yourself, are we set up for success? Will this set of interventions actually reduce readmissions if we deliver it well? And, you know, is there anything missing? Are we forgetting? Have we learned anything in our data or in our root cause analysis that makes us realize we haven't attended to a really important root cause, like palliative care? You know, not on these driver diagrams, but it doesn't mean it shouldn't be. It absolutely should be for pneumonia. So palliative care, or, you know, what are we doing with patients on event chronically? So there would be pneumonia-specific and subpopulations that you would want to add or build out your strategy to accommodate their transitional care needs and reduce their readmissions as well. So this is a kind of a little bit of a slide that you can bring again to your team for discussion. So moving to slide 25, then the great thing about having articulated your driver diagram is that lends itself to developing what I call a very simple operational dashboard. It doesn't mean it's easy to measure, but it's rather straightforward. So moving on to slide 26, this is just a reminder that we have a tool 6 in the Aspire guide, which basically, you know, is a simple PowerPoint that you can use if you like this to modify for yourself. So the operational dashboard for both implementations as well as month-to-month outcomes is in tool 6. And I'll go through some examples here in the closing minutes of the webinar. So moving on to slide 27, we've got, first and foremost, as I said, I alluded to, is you want to base your implementation dashboard off of the volume of patients that you have in your target population. So really, really great news is that in our NCHA knockout pneumonia scorecard, you have a starting point for at least your estimated volume of pneumonia patients. And so I've just showed you on slide 27 where you can find your annual, your most recent data for your I circled it there in the middle left-hand column of page 2 or 3 of this packet. And what I recommend you do is take a quick look. If you don't, maybe some of you already know, we have 5 pneumonia discharges a day. On average, 3 go to SNF and 2 go home. That's what I want for all of you. But as a starting point, if you don't yet kind of know offhand how many pneumonia readmission or pneumonia discharges do you have, it's here in your scorecard, and this hospital is just a random hospital we selected. This hospital happened to have 200 pneumonia discharges in the past year. So what do you say with 200? What do I do with the number 200? What I always do is I just do quick estimate, divide 200 discharges a year by 365 days in the year, and what you can readily see is, oh, we have less than 1 pneumonia discharge per day at our hospital. And so first and foremost, before we even think about risk stratifying or, selecting certain subgroups of pneumonia patients, I would say to this hospital, at less than 1 discharge per day, or really 3 to 4 pneumonia discharges per week, which is what they have, I think you should be serving all 3 to 4 pneumonia discharges per week with whatever relevant readmission interventions you have planned for your target population. So this would be a great example of a team where I wouldn't want you to stratify by LACE. I wouldn't want you to use 8Ps or any other mechanism to further stratify your pneumonia population. This hospital happens to be well set up to do something different for 1 pneumonia discharge a day, which is really only about 3 to 4 pneumonia discharges per week. So you see what I'm saying with that. So then you take your volume, and moving to slide 28, I want to make sure that you have, and again, the scorecard is a great illustration of this, and I recommend that you have a monthly administrative kind of internal dashboard, or you can use parts of what you get from the NCHA to populate this dashboard. This would be a monthly measurement basically about volume and readmissions and proportionality. So this isn't about interventions. This is more description of your total target population and the whatever your high-risk target population is on a month-to-month basis. So I put in the columns all in Medicare because my instinct is about half of you are focusing on Medicare and about half of you are doing pneumonia readmission work regardless of payer. And so, so whether you're all or whether you're Medicare, I just wanted to remind you to specify, again, according to your own aim statement. So I recommend that you know the total number of pneumonia discharges at your hospital. And then, of course, you track the number of readmissions following those discharges. That's the definition of a pneumonia readmission, and B over A is the readmission rate. And then I really recommend going back to webinar 1 that you track on a monthly basis, because as you can see, it's probably relevant to your implementation strategy in your driver diagram. How many of those pneumonia discharges are to SNF or to home care or to home? And if applicable, are you further substratifying your pneumonia patients by, quote, high risk? So in GH and I, if you're saying we take our pneumonia patients and then we use the LACE, or then we use Boost, or then we use some sort of other algorithm to identify high risk pneumonia patients, I want you to capture that in GH and I. And then finally, J is really important, because if you're not serving all of your pneumonia patients, then I want you to know what percentage of your pneumonia patients are in your target population. And oftentimes this is real food for thought, because let's just say you're saying we take all pneumonia patients and we run them through LACE, and anyone with a LACE score greater than whatever gets, is in our high risk pneumonia target population. Well, is that 5% of your pneumonia patients, or is it 80% of your pneumonia patients? You don't know until you measure it. And the reason why that's important is because you need to serve a high proportion of your pneumonia patients if you want to reduce your pneumonia readmissions. And so J is possibly the most important thing on here. So again, food for thought, and I welcome questions and follow up in future webinars on that. So moving into slide 29, we've got what I encourage you to do, which could come in two flavors. Again, you have this in your scorecard. What's your overall hospital readmission rate, trended monthly over time? What's your pneumonia readmission rate? And you might have a third line, which is what's your, quote, high risk pneumonia readmission rate if you're not serving all of your pneumonia patients. The next three slides, starting on slide 30, are process measures that I have found to be tried and true when driving to success. So I want to put these three process measures on your radar screen, and then we bring them together on an operational dashboard and we'll wrap up. So the first here on slide 30 is the percent of your target population served. So some of you said we're serving Medicare pneumonia. Our aim statement is to reduce Medicare pneumonia readmissions. So in this case, on this slide, the red line would be all of your Medicare pneumonia discharges, and the blue line would be all of the Medicare pneumonia patients that you actually served. And served is in quotes, whatever you say, whatever you define served to be. And this is real data from a team I worked with, and what you can readily see is until you actively manage and work to close the gap between the people in your target population and the actual patients that you're actively serving with your interventions, it doesn't happen by itself. This was an absolutely month in, month out quality improvement, problem solving. We plateaued there in the middle, as you can see, and we had to innovate our way out of that plateau, and we ultimately closed the gap. There are many things that go behind the success story, but bottom line, I want you to have the power of this type of data, because it's only when you close the gap between the target population that you want to serve and the target population that you're actually serving that you can possibly get readmission rate reduction. Next process measure on 31 is timely contact post-discharge. And I use that term on purpose because timely contact is are the important words. Timely meaning within 48 hours, contact meaning any kind of contact. It might be a home health visit. It might be a text message. It might be a PCMH-based nurse care manager phone call. It might be a circle back phone call with the SNF. It might be a hospital-based discharge phone call. And so what you really want to ask yourself is the process according to serving the patient. And so the patient can be served in many different ways. You don't have to do all of the work, but you just need to have the infrastructure. If you're not going to do all the work, you need to have the infrastructure to know when the job is being completed, basically. And so again, you can see the same team. This did not happen by itself. They basically started doing post-discharge follow-up phone calls in Q1. They worked harder and got to Q2. They hit a plateau, and then they innovated to get to the performance in Q3. The innovation, texting. So they would have never gotten to that Q3, 4, 5 performance that you see if they hadn't gone from phone only to phone or text. Slide number 32 is a reminder that when you start a program, your staff, yourself, all of us, we don't start off the most efficient and effective versions of ourselves or of the work that needs to be done. And so again, this is the same team and with the same FTEs. And what we tracked was patient-facing interventions per month. And what you can see is when the team started, we were doing a lot of meetings and a lot of root cause analysis and a lot of relationship building, and we were having a lot of patients refuse our services, if you will. And so you can see we had very, relatively low patient-facing contacts in those first 4 months. And then we innovated, as you can see, a big jump in performance twice. And so you can see a couple of the ideas that came out of this experience. But we started asking ourselves, do we all have to show up to the hospital to get this transitional care work done? And so we started liberating workflow and how, and really prioritize the transitional care team. We prioritized home visits and SNF visits over team meetings in the innovating and saying what in the service of the patient, because it's only in the service of the patient that we can possibly reduce readmissions. So again, this is process measure number 3 that I recommend. Moving in quickly into slide 33, which is the operational dashboard. Thus, I like to stay really broad and, and I like you to define the parameters yourself, again, because I know you all have different interventions that you're deploying. So an operational dashboard, the basic elements are how many discharges and then you want to measure the total number of those discharges that were received your intervention while they were here. So maybe that's whatever served means to you. So too, then you want to measure the number of those target population discharges that were served once they left the building. So that might be, a circle back phone call was done, a post-discharge call was completed, a transitional care episode was completed, whatever you define as served. And then you might fill it out with some more granular measurements like I'm filling out here as an illustration for you on this table. But you basically want to see this month and last month. What a lot of teams do is they kind of aggregate year to date or program to date, but that by definition means we always did worse at the beginning and we do better and better over time. So by all means, what you want to do is just like the graphs that I showed you in slides 30, 31, and 32 is you measure your performance on a month-to-month basis so that you can see, hopefully, the improvement in your operations that you're making. So to bring it together on slide 34, tool 7 of the Aspire guide brings together all of the design elements in the design part of the Aspire methodology, the ASP part of the methodology. And so we've now covered all of that. You might like this PowerPoint deck. You might like half of the PowerPoint deck. You might not like the PowerPoint deck, but it's a best practice to think about bringing this information together so that not only you can consolidate the information for yourself and your team, but you can share it with cross-continuum partners, with ED stakeholders that you're going to reach out to, with primary care stakeholders that you're going to reach out to, and so on and so forth. So in summary, on slide 35, recommendations coming out of today's 3rd webinar for your month ahead is to design a multifaceted portfolio of strategies using a driver diagram to describe your theory of change, how readmissions are going to get reduced based on what you're doing at your hospital. Number 2 is when you look at that driver diagram, cross-check it with what you've learned from your root cause analysis and say, are we doing things that are actually addressing the reasons why our patients come back? And of course, that needs to be customized for our pneumonia patients. And we talked about some root causes of pneumonia readmissions in depth in webinar 2, so you can go back to that. Number 3 is develop an operational dashboard to track the implementation of whatever it is you've decided that you can and want to do. Number 4 is review your implementation on a weekly and monthly basis at the team level, not at the committee level, but at the day-to-day team level. And we constantly want to draw upon ourselves and our workflow knowledge to ask ourselves, how can we improve what we're doing day-to-day, week-to-week, and month-to-month? Because especially for those of you with year-end goals, you have to stay on a weekly pace if you're going to get to a year-end goal. Finally, share your pneumonia readmission design and strategy, possibly using Tool 7, or at least codify it so that you can make visible the work that you're doing. So, slide 36, thank you so much. I'm apologizing for keeping you 7 minutes over. I hope this was helpful and a good use of your extra 7 minutes, and I apologize to those of you who had to drop off. But I will look forward to your questions and following up with the items in the chat, and I'll turn it back over to you, Karen.
Yes, thank you so much, Amy. This was really good and very applicable. And it's good to see the participants being where they're that they're moving on analyzing the data. I do have one quick question that I want a clarification. I think Amber is looking at pulling by DRG. She's doing coding, concurrent coding. She said if we just use the DRGs 193 to 95, we'll be missing many of the pneumonias that were coded as secondary because PNA is a MCC. It's the coding in the coding world, and sometimes code secondary. So I guess, you know, her question is how should she really expand on that and really look at it from primary to secondary?
So, you know, when this might be a question to clarify with your data analyst as well, Karen, but when I ask for a readmission data analysis, I'm only ever asking for primary discharge diagnosis. And so that, to really great point, there's a ton of secondary pneumonia, like my surgical patient that also got pneumonia, right? They code out probably like their primary diagnosis. With regard to, this is a perfect application of clarity on your AIM statement. So, you know, hospital A might say, we are going to reduce readmissions, you know, for patients discharged with a implicitly primary discharge diagnosis of pneumonia. But another hospital in the knockout pneumonia campaign might say, we actually really care about all patients with pneumonia, primary or secondary, in which case you would want to say that in your AIM statement. You would want to construct your data analysis accordingly, looking for all patients in the hospital leaving with a primary or secondary diagnosis. And so, so take the same principles, but again, everything that I talk about, we always need to customize it for our own specific readmission AIM statements. So if you're focused on primary and secondary, put that in your AIM statement, conduct your data analysis accordingly.
That sounds good, yes, and that's a great way to think about it, and that's why it's so important. We're doing the CDI education right now across the state, and it's really important to have especially if you're using coders, concurrent coding, and that we heard a lot of best practices where they're embedding that right into the team with the transition team, as well as the clinical and the coding all are meeting together. So that really goes along with it. Thank you so much. I guess that would conclude our webinar for today, and I appreciate everybody attending. This information is going to be sent out. Trish is already sending out information on the tools and a highlight of this, and we'll be posting the recording and the slide deck, right, Sarah?
That's correct. Yeah, we'll be sending an email out to where you can locate the resources.
All right. Thank you so much, and look forward to next month's webinar as well. Thank you, Dr. Bowell.
You're welcome. Thanks, everyone. Have a great day, and good luck in the month ahead.
Thank you. Bye-bye.